What about the prevalence? Is it very common, uncommon, malnutrition? In a surgical patient. Now, whatever I am talking about, take in a surgical perspective, not in a general population. Surgical patient, that's our theme point, na? Causes and consequences in surgical patients of malnutrition. So, malnutrition is common in surgical population. Why? So, it may tune up to 50% of patients. Almost half of the patients may have malnutrition. Why is common in surgical patients? Yeah, number one, these are sick patients in a different, it's a heterogeneous populations, different cause of surgery. Okay. After many surgeries, particularly GI surgeries, gastrointestinal surgeries, patients unable to take food for few days, or because of the disease process, patient couldn't take food for previous few days. Okay. So that's why in a surgical patient, malnutrition is common. Okay. Or you are operating on a very overweight patients, obese patients with lots of other comorbidities. So everything has an implications in the clinical outcome. So what do you think? If you compare with the normal population, what will be the clinical outcome? Is it working? Working? Right? So what will be the clinical outcome? If you compare with the normal patients, same or bad or better? So bad, obviously. So I'll explain why is bad. So obviously these patients will have increased morbidity, mortality, and the hospital cost will go on because you have to keep the patient for a prolonged time. They'll be requiring more ICU support, more nutritional support. Okay, so overall stay will be longer. If the stay is longer, the cost will increase. Okay, so that's not a good from the patient's perspective or the hospital perspective. Okay. Now, what are the causes? So, what causes malnutrition in surgical patient? Just think, what can cause? Basically, these four, I mean, in a surgical patient, reduced dietary intake because of the disease process. Suppose some patients has cancer stomach with gastric outlet obstruction. So, what they will have? Whatever they will eat, they will puke, they will vomit. So, obviously, the dietary intake won't be like this. If you see some jaundice patients, like a cancer hit pancreas or periumbilical carcinoma with deep jaundice, first thing they will have is they will reduce their intake because of the jaundice, because of the disease process. They won't be feeling. Whenever we have some disease, what happens to our appetite? Appetite is the same, loss or decreases. So there will be reduced dietary intake. That is the most important cause in surgical patient. First thing will be reduced dietary intake. Second, reduced absorption. Okay, some disease process, say some inflammatory bowel disease or something, yeah, or some small bowel pathology. Mostly foods are absorbed from the small bowel. If some patient has some small bowel pathology, they will have reduced absorption. Okay, or some will have increased losses. How increased losses? Diarrhea, vomiting is very common in surgical patients. Okay, so and some patient will have increased energy requirement. Suppose a patient of burn, some patient of sepsis, they will require more calorie. So because of the extra stress, they will be requiring more calories. But with a normal intake or the reduced intake, they cannot meet their nutritional demand. So they will go into the cycle of malnutrition. So in a nutshell, these are the causes of malnutrition. So what are the consequences? Which system gets affected with malnutrition? Which system? Nervous system, cardiovascular system, gastrointestinal system. Huh? Come on. All systems, every organ system. Exactly. So it affects the function and recovery of every system possible. Because all the system require nutrition, all the cells requires nutrition. Malnutrition means there will be, see the other slide, there is loss on cellular, physical, I mean, it's on a cellular level loss, no? All the systems, they require nutrition. So if you have malnutrition, it can affect the function and recovery of every organ system. Because whenever we are, undergoing surgery, we recover from the surgery, no? Surgery is a stress, nothing but an extra insult. That's required to treat the disease process. But we need to recover from the surgical insult or the surgical trauma or the surgical stress. For that, we need a good nutrition. All systems, they require good nutrition. But that goal is not always met. So what will happen? Now come to this, very important. If you see a surgical patients, what will happen in a pre-op patient versus post-op surgical patient? What happens? Very commonly, what do you see? What happens? Say, a pre-op patients, normally most of our pre-op patients, they come in the OPD walking. After surgery, what happens? They are all lying down. Can they walk just like a normal person like me, like you, immediately? No. Why? They are in pain. There are lots of tubes, there are pain. Plus, very important, the muscle function is not like that. Have you ever seen spirometer? Spirometer, what is that? How many balls? 3 balls. There are single ball spirometer also, but 3 balls. If you see in the pre-operative period, most of the people, they can elevate all the 3 balls. But immediate post-op, if you see, none of them can lift all the 3 balls. Why? So that's why I'm coming. And if you see the walking, it's not like the pre-op, like in pre-op, there's a normal gait, not like that. There'll be slow movements. Okay. If they do spirometer, it's not like the pre-op things. So the muscle function declines in the post-op period. Okay. How? So weight loss is the most obvious sign of malnutrition. Because if we starve, what happens? Say, I am starving for 24 hours. What will happen? Who needs glucose? All the cells. But who needs that the most? Body will try to supply glucose to the brain. Because all the vital organs, all organs are vital, but more vital things. So, body will try to send glucose to the brain and all this. How they get glucose if I don't eat? How they get glucose? So what storage first? First ki hobe? Prothome koththeke ashbe? What is glycogenolysis? Biochemistry you have been taught, no? So first from glycogen theke glucose ashbe ki. Sei glycogen kothaye thake? Where does this glycogen stay? First liver. First liver. Okay. But that will get depleted over. Do we have enough glycogen reserve for say 10 days? For how many days we have? Usually by 24 hours the glycogen reserve is gone. Next, from where the body will try to have this. First 24 hours, liver glycogen will support you. Okay. They will break down the glycogen, they will make glucose. Next, fat. Then they will try to break down the fat and then the muscle. Okay. So that's the reason of weight loss, depletion of fat and muscle mass. So organ mass will also get reduced. But if you see, there is muscle loss, but the muscle function, they will decline before the actual loss of muscle mass. Muscle has 2 things. One is muscle mass, that get wasted. But before this wasting, you can see clinical wasting, the muscle function will get impaired first. Okay. So that's why, in a post-op period, you don't get spirometer well. Okay. And if you support the nutrition, the muscle function will return before the recovery, before the actual muscle mass gain. Suppose the patient has lost the muscle mass. You are now supporting the nutrition. Okay. So he will gain the muscle mass over time. But the muscle function recovery will be faster, or that is first to occur before the muscle mass gain. Got my point? So it's a muscle function which will be impaired in a malnutrition patient first. आगे function decline করবে আর কি, then muscle power মানে muscle actual mass breakdown হবে আর কি. Okay, so before the loss, before the muscle loss, the function of the muscle will get impaired first if you are undernourished, because for all our activities we need energy, we need ATPs, so they won't generate enough, so the muscle function will get impaired first, then the muscle mass. So similar, when the recovery occurs, the muscle function will come down first, then the muscle mass will build. Okay, so function of the muscle, that's most important. That's why patient cannot do spirometer. Okay, because the muscle function gets this thing. I mean, got my point? What will happen to cardiorespiratory? All organ systems get affected. So what happens to cardiorespiratory? There will be reduction in the cardiac muscle mass. If the cardiac muscle mass gets reduced, what will be the cardiac output? It will get reduced. If the cardiac output is reduced, what will happen to the perfusion to the other organs like kidneys? They will get reduced. So there will be reduced renal perfusion, reduced GFR. Huh? You have all read all this GFR, all this in the physiology, no? So everything, they are in cycle, no? Nothing happens in the body independently. They are all in a coordinated manner. So if one thing happens, the next thing will happen, the other organ will get affected. So if cardiac output is reduced, renal perfusion is reduced, GFR is reduced. So what will happen to the diaphragmatic muscle also? Again, the function, diaphragmatic muscle won't work well. If the diaphragm is not well, what will happen to the tidal volume? Tidal volume will get reduced. So patients, they post-op period very commonly saturation খুব কম থাকে. হ্যাঁ, আমরা সবসময় স্পাইরো করো, ইফ দে ডু স্পাইরো তখন একটু বেটার হয় আর কি. হ্যাঁ, সেটা কষ্ট করে পেশেন্টকে করতে হয় তখন আর কি. বাট ইফ ইউ ডোন্ট অ্যালাউ ইট, or if you don't tell it, or if you don't promote it, what will happen? If the patient doesn't take adequate respiration, if the tidal volume is less, what will happen? Normally when we take breath, what will happen? Air will go like this, trachea, bronchi, all the alveoli will be, exactly, they will be full with air. If you don't respirate, then what will happen? What will happen to the alveoli? If there is not enough air, they will cause collapse. Collapse means there will be a collapse, then consolidation, then pneumonia, and all the sepsis, all the cycle will come in the pictures. So in any surgery, particularly abdominal surgeries, definitely, abdominal surgeries, chest surgeries, the respiratory function is very important. That may not be very evident in the lap chole, because lap chole recovery is very fast. You don't have much physiological insult in lap choles. So you may not see these changes in a lap chole patient who is next day fine and okay. But in other patients, particularly GI patients, abdominal surgery patients, where the patient will be not having food for a few days, all the diaphragmatic muscle is very important then, the function of diaphragmatic muscle. If they do not take adequate tidal volume, not enough respiration or enough spiro, less amount of air will go. So the alveoli will be collapsed. If there is no air, it's a bag, no? So it will get collapsed. So it will cause collapse, consolidation, pneumonia, everything will happen. Yeah? Okay. Next, what happens to the GI function? Affects every organ system. So what will happen to the GI system? If suppose we are not taking orally adequately, what will happen? Suppose I am not using my muscle for few days. Very commonly, anyone have undergone plaster for some fracture? Anyone? I had a fracture ankle when I was in third year MBBS. So they put me on a below knee plaster, okay, and they got a working iron. So you can work with the plaster, but that's not working iron. There is a rod like this. You can work on this, but actually I am not using the muscle. So when they remove the plaster after 6 weeks, I was surprised to see that my right calf muscles, they are just half of the left. Not denervation, disease atrophy. It's not denervation. Nerves were intact. I had just a fracture malleolus. So it was a disease atrophy. So if I'm not using this thing, my muscle, they will have disease atrophy. It was just half, and it took almost a month to be, parallel, like this. Okay. So similarly, if we don't eat, what will happen? What will happen? Mucosa. See, the malnutrition, there are changes in the pancreatic exocrine functions, intestinal blood flow, villus architecture, and intestinal permeability. So what will happen to the mucosa? There will be similarly some loss in the mucosal things. The villus, intestine has villi, remember in the anatomy of this thing, pathology, villi. Villi will get atrophied. Similar, if we don't use oral route, they will get atrophied. So once the villus gets atrophied, what will happen? The absorptions and everything will be impaired. Okay. So similarly in the colon also, it loses its ability to reabsorb water and electrolytes. Okay. And both secretions of ions and fluid will occur in the small and large bowel. It may cause diarrhea. Already nutrition is at stake. Then now I have diarrhea. So the nutrition, undernutrition will get exacerbated. Yeah. Okay. So if you don't eat, so your GI function also, get more impaired. Intestinal villus atrophy. For the colonic changes, the colon will lose because there will be some changes in the colonic mucosa. Normally, colon absorbs much of the water, okay, and that gives the final stool consistency, because stools are normally solid because the colon absorbs water. But if the colon doesn't reabsorb water, the consistency of stool will be, how much of the water comes to the IC junction? How much of water comes to IC junction per day? IC junction, ileocecal junction. And how much of the water is excreted via stool per annus per day? Almost 10 liters of water or the fluid that comes to reaches IC junction. But via stool and all these, maximum 1 liter gets excreted. So 9 liters will get absorbed by the colon. If the colon doesn't absorb that amount of water, what will happen? All this water will come to the stool. So there will be diarrhea. Okay. So that's why we have a very high mortality rate in malnourished patients, because this will go on a vicious cycle then. Malnourished, unable to take food, intestinal mucosal changes, further problem in the reabsorption, diarrhea. So, okay. What will happen to the immunity? Immunity will be impaired because all the functions, cell-mediated immunity, side complement, phagocyte, all are really impaired. Okay. So ultimately there will be immune function impaired. So if the immunity is impaired, what will happen to the wound? What will happen to the wound? Wound healing? Wound healing will be, hampered too, because all of this cytokine, everything is, they are not in the proper fashion. For wound healing, everything should be in a proper fashion, in an ordered fashion, step-wise. Remember the 4 steps? Okay, so everything is related. So they won't happen in that fashion. So there will be delayed wound healing. Infection risk will be increased because this, our guard dogs will be not working. Okay, so they will promote sepsis. Okay, that's why you have a high mortality. So these are the causes and consequences. Now, slightly, bigger picture. If you see nutrition and surgery, so I will discuss these 4 things: nutrition and surgical patient, assessment of nutrition status, assessment of energy requirements, and enteral or parenteral nutrition. You have to support nutrition. If you find that this patient is not nutritionally adequate, you have to support nutrition, either enteral or parenteral. Okay. So now, surgery and nutrition. What we are discussing is a nutrition in a surgical patient. What will happen? Surgery is a stress. Surgery is an injury. Surgery is an insult. So what will happen now? First class, metabolic response to injury. Remember? So what are the metabolic responses? You remember? So surgery is nothing but an injury. Surgery is nothing but an insult. Surgery is nothing but an extra stress. So now the response of the body will be metabolic response to the injury. So what are that? So it's a recap. What happens? What are the metabolic response to injury? First class. Who took? I think Atanu took it. So what happens? Metabolic response. Yeah, so a counter-regulatory hormones, they will go up. All the cortisol, glucagon, catecholamines, the stress hormones. If there is stress, the stress hormone will get released. Simple. So that's why catecholamines and the cortisol is steroid, no? So their level will be up. What will happen to the inflammatory cytokines? How to divide the cytokines? They are pro-inflammatory and they are anti-inflammatory. First, what will happen? Who will come more? Pro-inflammatory. And normally what happens in a metabolic response to injury? Gradually, the anti-inflammatory cytokines come and they mitigate the system. Suppose there is some problem, some local jhamala, what will come? First, the policeman will come. They will try to dissipate the situation. They will make it again peaceful. So similar in body, whenever there is some injury, some stress, some insult, first the pro-inflammatory cytokines will come. They will cause some inflammation. Then the anti-inflammatory mediators will come. And they will now try to settle the issue. Okay. Similar. So, pro-inflammatory cytokines. Who are the pro-inflammatory cytokines? TNF-alpha, interleukins, particularly IL-6, IL-8, even IL-1 also. So, they will come. So, they will all get increased. So, they will start. What will happen to the proteins? Breakdown, catabolism. Okay. So after surgery, all patients will be in a state of catabolism. Now, more the insult, more is this response. More the insult, more is this cycle or more is this response, they will be more prominent. So that's why minimal invasive surgery, there is some class on minimal invasive surgery, no? Minimal invasive surgery, there was class. So what are the advantages of minimal invasive surgery? কম হবে না তা না, কম হবে, যে কোনো ইনজুরিতেই হবে। বাট ইফ ইউ সি না, দ্যাটস ওয়াই ল্যাব কলিতে কি হয়, ল্যাব কলিতে যেহেতু তার হোলস আর স্মল, এই রেসপন্স বা ইনফ্লামেটরি রেসপন্সটা অনেক কম হয় কম্পেয়ার টু অ্যান ওপেন সার্জারি। বাট মেনি অফ দ্য যেগুলো বিগার অ্যাবডোমিনাল সার্জারি সেগুলো তো মোস্টলি ওপেনেই হয়, তাই না? বা ধরো ইভেন ইন ল্যাপেও তুমি যদি দেখো যেগুলো ধরো ক্যান্সার সার্জারিজ, সেখানে ডিসেকশন ইজ মাচ মোর. You have to take the organ out, you have to take the lymph nodes out. So the more insult you give, more the response. Simple. So the lesser the insult, lesser is the response. So that's why this protein catabolism is more in the open surgeries, in the bigger surgeries, in the cancer surgeries. Okay. So that's why they are major surgeries. Now what will happen to the insulin? Insulin resistance. Yes. So insulin resistance means what will happen to the blood sugar? Increase. So that's why after surgery, always these patients are a hyperglycemic stage. They'll all be diabetic. Okay. And What will happen to the muscle? Protein catabolism is on, so muscle will get, there will be some destruction of muscle tissue, muscle mass loss. But before the muscle loss occurs, muscle function will get, first the muscle function, then the actual loss. Okay. So that's why, see, these are the role of surgery basically. Surgery is an insult, is an stress. So surgery is an injury basically. So we will have the metabolic response to injury. Huh? So now, how to assess nutrition? You can check the body weight. You can see how is the loss of weight. You can check the height. If you compare body weight and body mass index, which one is better? Body mass index. Why? Because exactly. So the weight actually depends on the stature of the patient or stature of the person. If you're very short, obviously they don't need this thing, very high weight. Okay. So BMI is a slightly better indicator of nutrition compared to the body weight, because that includes height also. What is BMI? Weight in kg by height in meter square. Weight in kg by height in meter square. Okay. So the other things are upper arm circumference, upper arm muscle mass, some checks, skin fold thickness, but these are very not commonly usually done. Okay. But if you see the anthropometric measurements, if someone doing some study, then they have to do all these things: upper arm circumference, skin fold thickness at triceps. What about serum albumin? Normally we check very commonly how is the albumin. Albumin is, what is albumin? It's a protein. So it's a surrogate marker of how the protein reserve is. Suppose someone is free of albumin is 2.5. Is it adequate or not? What is the normal level albumin? Normal level of albumin. That's a protein. 68 kilogram. Albumin level koto, serum albumin level koto. Normal serum albumin level. কত দেখবে দুটো জিনিস ব্লাডে গ্রাম পার ডিএলএ আমরা বলি, কি কি দুটো জিনিস গ্রাম পার ডিএলএ? একটা হচ্ছে হিমোগ্লোবিন আর হচ্ছে অ্যালবুমিন। হ্যাঁ, বাকি সব দেখবে মিলিগ্রামে থাকে। এই দুটো জিনিস থাকবে গ্রাম পার ডিএলএ থাকে। সো হোয়াট ইজ দ্য নর্মাল অ্যালবুমিন লেভেল? 3.5 to 5.5 normally, 3.5 to 5.5. So anything below normal is underscore. Okay. What is the half-life of albumin? Half-life of albumin. Anyone guess? 3 weeks. Half-life of albumin is 3 weeks. So if a nutritional changes, the albumin changes, it will take time because half-life is long. But if you see after surgery, what happens to serum albumin? It decreases. Even someone is normal albumin, it will get decreased. But what is the cause of decrease? Half-life is quite high. So it's not because of that. But if you see in the, you remember TRE? The escape rate is because some dilatation, vasodilation, permeability increases, so escape rate is high. So that's why immediate post-op the albumin level gets reduced. Okay, fine. So BMI is a more optimal, but if someone is very overweight, then BMI is a poor indicator because BMI doesn't differentiate the muscle mass or fat or something. They don't differentiate. If someone is overweight because of the more fat, BMI will show the right BMI, but he may not be correct. So in overweight patients, they have a low sensitivity. Otherwise, BMI is okay. What is this? At least you must be aware of this. You don't have to remember everything, but you have to remember this tool. It's called MAST, Malnutrition Universal Screening Tool. Because in bigger hospitals or in a proper unit, there is a nutritional team, dietitian or nutritional team. And whenever they do some research on all this, they always follow some sort of screening tool, like either malnutrition screening tool. This is very easy. There are other also. It's called NRS, nutritional risk score. Okay, so different institutions, they follow different protocols, but the clinicians normally don't use it normally. Normally the nutrition support team, because in abroad everyone has a designated role. So the nutrition support team, they all follow some, because you have to be objective, no? Otherwise I may feel, hey, he may be undernourished. But how to objectify the patients? So that's why you need a scoring like this. What is this? So they include BMI or unplanned weight loss in the last 3 to 6 months. Okay. See, if BMI is less than 18.5, they have put a score of 2. If weight loss is more than 10% in the last 3 to 6 months, they put a score of 2. Okay. And the patient is acutely ill and likely that he or she won't take any food for the more than 5 days, the score is 2. So you add the scores together and calculate the overall risk of nutrition. Score 0 is low risk, 1 is medium risk, and 2 or more is high risk. So if anyone happens individually, that's a high risk patient. That means you have to support the nutrition of these patients. So the nutrition and dietitian will come and they will have a repeated visit. Okay. So they will, why? Because you have to identify the high risk patients. Who is nutritionally high risk? Nutritional depletion are beshi hote pare. So you have to supplement that way. And you have to supplement nutrition and again see how they are improving. Yeah. So that's why you need an objective tool. So this is a very simple and rapid. Okay. And the total mass score, 1, 2, 3. The total mass score is important. Okay. Now what is assessment? Assessment of energy requirements. We all need some energy. We have some basal metabolic rate, some basics. There are some formulas. There are some formula, Harris-Benedict formula. I have come across in biochemistry, Harris-Benedict formula. Some weight and all these height, weight. They have some, this is the amount of calorie we need. This is the amount of protein we need. The dietitian make it as per your anthropometric measurements, your height, weight. They put a chart. You take this, you take that. So dietitian, they will make these charts, no? Depending on this. Say someone is diabetic, so they will off the sugary things. They will make your food like this. Okay? That you require this amount of calorie, this amount of protein. Now, if it is an uncomplicated surgery, slightly higher than BMR you need. Okay? But if it's a complicated surgery, maybe almost 1.5 times. If you need 100 calories, you will be requiring 150 calories then in a complicated ones. So your calorie requirement is more. Okay. In ICU patients, 25 to 30 kilocalorie per kg, at least 25 kilocalorie, at least. If the patient is in sepsis or trauma, they will be requiring almost twice the normal this thing, because your energy requirement is more than. So you have to assess each patient, each surgical patient, you have to assess how much energy this patient needs. So you have to supplement the extra energy. If you don't give this extra energy to the patient, suppose a patient is in a sepsis or is a traumatic patient, if you don't supplement the energy, what will happen? Again, it will affect every organ system. The muscle won't work, respiratory muscle won't work, they won't take adequate respiration, cardiac output won't be proper. Okay, it's not only the management of the disease process, it's also management of the nutrition. If you suppose it's just like in a war. If you are going to war, and you are not having food, you are just without food, everything, how can you fight? Simple, the simple concept, no? So you have to supplement extra energy to the patients. So if someone is in sepsis or some trauma patient, they will be requiring more nutrition, not the usual nutrition. Whatever is required, what is normal, give just the double amount of this thing. So that provision you have to make. Otherwise, they won't recover from the consequences of malnutrition. Every organ system will be at stake. Okay. So that's the assessment. So now what? Enteral versus parenteral. Which route is better? Enteral route is better or parenteral route is better? Always. Always remember, whenever possible, the basic rule of nutrition is whenever possible or whenever feasible, use the enteral route. Okay, that's the basic. Enteral is definitely better than parenteral. Then why parenteral is there? Even if coma, I can put a ice tube and feed the patient. But sometimes the patient